Please be aware that this episode discusses sensitive topics that some listeners may find distressing. If you or someone you know has been affected by any of these issues, please refer to the help and resources listed in the show notes for details of organisations that can provide support. Welcome to Mindful Merseyside, the podcast series which aims to improve everyone's physical and mental health in the Liverpool City region and beyond. This episode of Mindful Merseyside is called The Drugs Don't Work, and we're going to be discussing chronic pain and opioids that are sometimes used to treat it. We're going to be getting into the problems caused by opioid use and why it's not necessarily the best thing to use for chronic pain, how it can affect patients and their families, and we'll be delving into problems with addiction and how to combat that. Right, let's get into the episode. Now, there's quite a few people on this episode, so I'm going to go around and kind of get you all to tell me what it is that you do rather than me telling you what it is you do. But I would like to welcome Kathy Montgomery, Dr. Bernard Frank, Ruth Devonshire, Janet Beattie and Yasir Abbasi, who's joining us on Teams. Kathy, let's start with you.
Hi, I'm Kathy Montgomery. I'm a reader in psychopharmacology at Liverpool John Moores University, and I study the effect of substance use on the brain.
And Bernard?
I'm a consultant in pain medicine with a background of anesthesia, and I run a opioid clinic in the Walton Center for the last 14 years or so, where we help patients to come off strong painkillers.
And Janet, what about you?
I'm an advanced nurse practitioner in pain medicine, and part of what we do is support patients reducing opioid medicines.
And Ruth?
I'm a pain nurse specialist, and I work with Janet, and we support the patients to reduce their opioids.
And Yasir, thank you for joining us. Can you just tell us what it is that you do?
Hi, everyone. My name is Yasir Abbasi. I'm a consultant psychiatrist, and I specialize in addiction psychiatry. I'm currently the executive medical director at an organization called VIA. We provide drug and alcohol services across England, across various sites. And I have a special interest in people who get addicted to prescribed medication, particularly opioid painkillers.
Now, you've mentioned opioids there, and that is what we're going to be focusing on in this episode. Bernard, for people who don't know, what exactly are opioids, just to start us off?
So opioids are kind of strong painkillers who are derived from the poppy plants. So they are from the family of morphine. They're obviously natural ones, so like heroin, who are grown on poppies and then get condensed into illegal drugs. But heroin is also used as diamorphine in medicine. And then there are synthetic ones who are just derived from the molecule of morphine, and they work on opioid receptors, which are strong kind of receptors in the brain to numb pain. And they're all kind of related, and they have obviously the property that they can make you quite dependent when you don't take them. So in medicine, we mean that they can make you physically relying on the medication. So if you stop them abruptly, you get withdrawal symptoms. And that's one of the biggest problems patients experience with this kind of drugs.
And they can be used to treat chronic pain. And what is chronic pain?
Again, I jump in here, but it's basically anything like pain for longer than 3 months. So Janet has worked in acute pain as well, and that's more the postoperative pain you see in hospitals, or short-term pain, whereas chronic pain is when pain doesn't get better for 3 months, and then there are different other effects take place, and that leads usually to quite significant disability if it doesn't get treated properly.
And how many people does this kind of thing affect?
I think the combined studies, looking at the incidence of it in the UK is probably 20% of the population.
Oh, wow.
So it's quite a big problem.
Okay. And why is opioid medication not the best treatment for chronic pain then?
I think chronic pain has been treated with opioids for quite some time, but after some time you lose the effectiveness of it. And if it's not focused on, trying to use the period to make a difference to patients' activity levels and quality of life, then you're getting into the problems of the opioid medicines in terms of the dependency formation, you treat the withdrawal symptoms rather than the pain, and then patients, become really into a problematic situation that they have to take the medication, otherwise they experience withdrawal symptoms.
Right.
And no studies have examined, the effect of it for more than 3 months, and that's the reason why there is no scientific proof or evidence that they have a role in long-term management, and that's the reason why we come away from using them at similar ways like in cancer patients where they are still indicated.
And Janet, do you see side effects from this type of medication?
Yeah, frequently patients will say, particularly from a longer term perspective, is that opioids can have an impact on their cognitive function.
Okay.
So they can feel quite drowsy during the day. Family members might notice that they're falling asleep either mid-conversation or during a meal. Also, it can affect ability to fight infection, bone health. So there are longer term issues in terms of tolerance, dependence and efficacy of analgesia. You know, patients end up on quite high doses, but unfortunately it's not continuing to offer them any sort of significant benefit or significant relief. So as Dr. Frank was mentioning, it doesn't help their function, and what they want to be able to do is to be able to get out of the house and things like that.
And Ruth, obviously you're dealing with patients and their families. How do you see the effects of long-term opioid use on those patients and families?
I think in the Walton Centre, it's our job, once they're referred to us, via their pain clinic or their GP, and they're identified as being on high doses of opioids and needing to reduce, we will sort of support them to come off it. And we often find that when they first arrive at the clinic, they're very, very anxious, about reducing their opioids. They often tell us that they struggle to engage, with their family members. They struggle to find any enjoyment in their lives because they're in extreme pain. The medications aren't helping and the side effects often outweigh the benefits.
And Kathy, what are your thoughts?
So it's really difficult because obviously patients want some type of pain relief, but if you've been on a long-term opioid script, you get tolerance to the effects of the opioids. And, from a psychopharmacology point of view, this can be physical tolerance, whereby your body adapts to the opioid and you need more and more of it to get the same effects each time. But it can also be behavioural tolerance. So you want more of a pain-killing effect than you were getting on the dose previously. So the dose gets escalated, and very often patients are cared for by their GP in primary care. And there's a really big resource issue for GPs, whereby the quickest thing for them to do might be to escalate a dose or roll over a prescription. And that's not necessarily the best thing for a patient. And then they end up, at the Walton Centre Clinic on higher doses of pain-killing medication.
So I think now might be a nice time to hear from some patients that we've spoken to. And I caught up with Margaret Arnold and asked her what her experience of using this type of medication was.
My Matrophen patches that I started on. I started on them years ago. I can't even remember how long ago. It started at 50 micrograms. And then it gradually went up and I was on 100. And over the years, I thought nothing of it because I thought, well, it can't be that high a dose because I still got pain. But when I had a consultation with Dr. Galarsi, he set out with such a high dose of morphine patches. I said, well, why are you on that high? I said, I don't know, one of those things. So he said, well, he couldn't do anything for me regarding the pain till I was down off them. So, okay, so a while later, waited a long time, I got sent to Ruth and Janet. And I got down from 100 micrograms. They brought me down. And I think it was I don't know whether it was when I was on 50 or 80 micrograms. They took me off them and put me on the tablets. So I went on the tablets. I think I was having 18 milligrams a day. And then after a short while, they decreased the dose by 10 milligrams a week. Now, the first time I came off them, I did have bad withdrawals because I'd been on them for years. And it lasted about 3 or 4 days, but I spoke to Ruth and she assured me, we should go, which it did, it went. So the second time, when a couple of weeks later, when I was getting reduced again, I was quite dreading it because I thought they'd be back. They weren't as bad. And then after that, I had nothing, no withdrawals or nothing. So came down. And then on the 3rd of December, I was going on my holidays and I was right down to 5 milligrams a day. So I went on my holidays, came back, and I think I had a couple of days, maybe a week left. I had them, and then I came off them altogether, and I had no problem coming off them. So that was it, basically. So last November, Dr. Galati, he gave me the injections that I needed in my neck and my shoulder, and that was fine. So I came off morphine altogether. To be quite honest with you, I didn't know that 100 micrograms was a high dose. I didn't have a clue. And I still had pain, so I didn't really think that you were doing much good. But sometimes when you're in the shower, you lose one and you wouldn't notice it gone off your arm. And after a day or so, you start to get that feeling, the withdrawal. And I put one back on. So as long as I had one on, it was fine. And then, but the best thing I ever did, the best thing Bruce and Jealous ever did, was take me off them, put me on the tablets and reducing it to nothing. So I don't have any problems now. I came off them in January and I don't have any problems now. But I still have back pain, and I've had that for years. But no, it's fine. It didn't affect my life at all, really. Because I had them for that long, I didn't really take any notice of them. Ruth and Janet were amazing. They really were. I saw Ruth more than Janet. And I used to go in there and I knew I could ring her up at any time. I knew, and I did ring her a couple of times, but they were absolutely amazing. They were lovely people. What would I say to people? I'd just say, go for it. The first time, well, according to Ruth and Janet, I did amazingly well. She said, I wish all the patients were like you, because after the first time and the second time, I didn't have any withdrawals. And she said, I thought everybody was like that, but she said, no, some people are bad. But I would say, definitely go for it, because to come off them, to take nothing after taking morphine for years, then I'd do it again. I'd do it again. But I'm wondering, some people say they think so, some people say they don't. When I came off the morphine, I was off for about a week or so, and then I got terrible bowel problems, and I've still got it now. I was in hospital last week, and I found it strange that when I was on morphine all those years, every now and again, as everybody knows, it does cause constipation, which it did. But I've never in my life had diarrhea like I've had. And I thought it was coming off all the morphine in my system. But some doctors say yes, some say no. So I really don't know. But I'd do it again.
Margaret, thank you for sharing your story with us. And I also spoke to Helen Arnold-Edge to see what her journey's been like.
I used to be a complete gym bunny at the time. I was working full-time. I was a full-time carer for my elderly father who had dementia. I got married in 2013. I was a single for quite some years before that. And I had 4 children and a husband. So life was hectic, but I wouldn't have changed it for the world. And then unfortunately, I had 2 accidents in work. And that was the start of my journey then with all the medication. After I had my accidents and I had to come out of work completely, I tried every other medication, everything that was, that you could possibly take, from fluoxetine, duloxetine, amitriptyline, pregabalin, gabapentin. And on one of those medications, I actually put on 4 stone in just 6 months. So after that, then it was a thing with my doctor of I was on high doses of them. I weaned off them over, say, a 4 to 5 month period by my husband at home before I could even on to the opioids. And at the time, I didn't really know much about opioids at all. It was a new thing. I had about morphine, but I was never even given morphine. I was straight on to fentanyl, I'd never heard of. And I had these in patch form, changing every 72 hours. It started off on a lower dose, but I was still taking a lot of other painkillers on top of those as well. I also have a prescription as well for tramadol, which was given to me. And I've been on them for a considerable amount of time. 2008, And that was from an old sinus infection. So it left me with a lot of headaches and so forth. And they were when unnecessary. So I was topping up the fentanyl with my tramadol, paracetamol, ibuprofen 400, Solpadeine Extra Max. And so to stop doing them extra ones, my doctor was just upping and upping no limit till I got 100 to the top dose I could possibly have. And I was on them nearly 7 years, I think it was. I couldn't drive because I couldn't function. Every third day, my body had just completely and utterly slumped. And I'm not one of them people who'd sit and look at things on an internet and so forth. And understand why I was feeling this way on my third day, which was my changeover day that night. And when I asked the question about it, I was told, from my pain specialist, keep my body waiting for its next kick. So basically, it's like a drug addict. And I never drove my car again. As I say, I couldn't function. I stopped taking the dogs out for a walk. My anxiety just through the roof, and which that hasn't stopped since. I've never got that back. I just turned a home bird. And this was someone who used to always be out and on holiday and driving everywhere. I mean, my brothers, I've had 2 elderly blind brothers who lived in Somerset. And every 5 to 6 weeks, I'd do that journey back and forth. Not a problem. I won't think twice about it. I'd drive to Cornwall and to Devon to meet my friends on holiday. All that stopped. All that completely and utterly stopped. What made me realise that I wanted to come off the opioid medication is I lost my father in 2019 at the age of 91, a grand old age. And I thought, I'm not even going to get anywhere near that. Not going to get anywhere near it while I'm pumping myself with all this medication. There's me and my husband now and two our little fur baby. I want to get off this stuff. So it was in my mind for quite some time, but I was scared of how I was going to do it. And more so what was going to happen when I come off these. What was, how was my pain going to be? So I managed to eventually get in and have my appointments. And I went into a detox in the Walton Centre itself for a week in July of 2023. I was meant to have had an esketamine infusion. And I'm that strong-willed, or as my husband says, and my father used to say, I'm stubborn. I was adamant I wasn't going to have it. I was adamant. After everything else pumped into my body, I wasn't having anything else stuck into me. So they were giving me different medications to come off it. And I literally just took the patch off. The night I got in there, the patch come off, and we were just waiting then for the cold turkey to kick in. It did not kick in as bad as what I thought it'd be. I had 3 small doses of ketamine as an oral form. And that, apart from any other medication, which was going to be going forward in the 3 months afterwards, that's all I had. After all the anxiety and the build-up of the nervousness and feeling ill about going in, but I knew it was going to do me good as well, I think it's just the fear of the unknown. I'd recommend anybody to do it. And my life since I've come off the opioids, it's not changed dramatically, but it's given me, just let's say, I now actually see night and day. Me and my husband ourselves, he has full-scale conversations with me, whether to take it all in or not, it doesn't matter, but he's still having them conversations with me these days. If he goes out, well, he does go out, he does all our shopping. Even if I don't feel like getting dressed and going out, I might just be in my pajamas and a jumper. I'll still go in the car and sit with him in the car while he goes out and does the shop. I never done anything like that beforehand. And just explaining this now, just saying this out loud, because it's not very often you do get a chance to say it, just saying it out loud, I've got a smile on my face. Don't get me wrong, my pain symptoms are there, but I do have I am having ongoing treatment. And whilst I'm under the Walton Centre, and since this journey has started, they've never left my side. So I'm having every fortnight, I'm having specialist physio, and I build a bit of rapport now with Amy. So if my husband can't actually come in because he's on a call with work, because we have to fit it all in my husband's work, I'm still not driving, I've got the confidence now to actually go in to see Amy myself as well, which that would never have happened. The other thing that I have noticed since I've been off the opioids as well is I'm a lot more not as muzzy-headed. I used to feel like I had a patio slab permanently pressing down on the top of my head. That has lifted, and that lifted practically straight away, that as well. And the other thing as well is I have done a long journey since then. Even doing a journey, a 2-hour flight somewhere, within the first 10, 15 minutes, I could feel my legs and my ankles exploding. So after coming off that, with it being our 10th wedding anniversary in November, my husband booked for us to go away, but I had an 8-hour journey, an 8-hour flight. I was dreading it. So I'm there with my sexy support stockings on. Oh my goodness me. There was no swelling in my legs. I've had nothing like that since. They are the two big things. And I think sometimes that gives me a bit of confidence as well. And it gave me a lot more confidence when I was actually on my holiday, because these days we cruise a lot, because it means my husband can do what he wants to do if I'm on my bed rest days because of my fibromyalgia. And even just not looking down and seeing those swelling, or having people not looking at you when you're in a pair of flip-flops or sliders, and I'm sat round the pool, and it's just lovely not having people looking and thinking, oh, I wonder what's up with her there. And it's just that it takes that bit more confidence, and it was a nice feel. It was a really nice feeling that. But yeah, fingers crossed up to now, I'm doing well. I'm positive for what I'm going to be doing, going forward. And I'm looking forward to the next stages. No one ever is looking forward to going to hospital. And I don't care what anyone says. You're not looking forward. But you know what? I am looking forward to my appointments, because I know that I'm not on that horrible medicine. I'm scared of what that may have done to me in the past. I know I've had a liver scan done, and I know it's given a fattier liver in 2.5 years. I eat so well and healthy at home. Yeah, I can't exercise, but it's giving me that as cause. And as the doctor said to me, she's done my scan, chances that is because of the medication. So at the moment now, I'm really more adamant than anything that I'm going to try and reverse as much as that as I possibly can. I want to live a long time, and I want to live healthy. Dr. Frank and them nurses, Janet and Ruth, they're absolutely tremendous. Absolutely tremendous. The support that they give to you is it's wonderful. Every time I'm praising them, every time they come on the phone, I'm just like, oh, thank you so much for everything. It's that I'm so grateful to them.
So we've heard from Margaret and Helen, who are patients, but I'd be interested to hear a little bit more about, from your point of view, Janet and Ruth, being in the situation, dealing with patients, what kind of challenges do you face, and how are those patients feeling when you first see them?
I think when they first come to clinic, it's obviously very daunting. Yeah. They're really apprehensive. They're not quite sure what to expect. And it's trying to offer that level of support to get to engage, really, because if we can't do that, patients are not going to want to engage, and they will, obviously, the repeat prescriptions, if they're on really high doses, will continue to be flagged by other medics or GPs that they come into contact with, and that sometimes can be a point of conflict. So frequently patients will refer to difficult relationships with other healthcare professionals. So I think what we try to do is just put our perspective out there in terms of we are here to support, we're not here to judge. That's really important.
Yeah.
I think it's also really important that we commend patients as they go along the process. Even with small steps, it's really important, because that's quite important to them to realise and reflect how well they're doing through this process.
I think we appreciate what a difficult journey that it is, that they have to go through to reduce their opioids. And we know that they'll feel better at the end of it. But when you're in the middle of experiencing some increased pain and withdrawal, it can be very, very difficult, which is why we've got the opioid helpline, so that patients can contact us, because their GPs might not be as accessible. And if they're experiencing any side effects from the opioid withdrawal, we can talk them through it and offer some reassurance. And I think something else that we offer is listening to the story, isn't it? And
absolutely.
A lot of people haven't felt believed along the way, especially if it's a primary chronic pain and they haven't found an organic cause for their pain. They felt disbelieved and let down by healthcare professionals along the way. And I think it's important for us that they know that they are believed and they are supported, and we're not judging them. We like to have a really open relationship so that they're able to be as honest as they can with us.
And I guess it must be potentially quite isolating, because it's not, as has been mentioned already, it's not the same as saying, I'm addicted to Class A drugs. If people are saying to their friends or family, well, I'm addicted to painkillers, I'm guessing that sometimes people might not understand the gravity of that situation and how it's affecting those people.
Yeah, oh, absolutely. I think as well, isolating within families. So patients might avoid certain situations, avoid social situations, simply because they're concerned that they might have a flare of their pain at that point. So they won't go to the wedding or out for dinner or whatever it might be. So they become isolated from a sort of social aspect and for community, but also particularly within families, because their role again changes within the household and what they're able to function and what they're able to engage in and what they're able to do. And it's, as Ruth said, it's about listening to that. So part of our initial conversations are just around checking in with patients and where they feel they are, what challenges they've got, what the limitations of their pain is, but also what hopefully we might be able to support them to get to, because patients are very driven. A lot of patients will want to stop their opioids because they appreciate how much it's taking away from them in terms of, as I mentioned before, cognitive function, any other unpleasant sort of side effects, really.
So what I would like to also add there is the fact that the type of clients and patients that are visiting Walton Centre would be doing so at the extreme of the presentation, where the pain has become quite difficult to manage and they're on multiple medications. It takes quite a number of sequence of events to get to that point. Now that we feel within the addiction services, there are a number of individuals in primary care who are currently prescribed this medication, who we can kind of prevent from getting to that point by educating them, by informing them about the impact of opioids and how they can be useful, but as well as long-term use cannot be as beneficial as they think it would be. And it's very important to do that preventative work rather than try and get them to a tertiary care center and help them out at that point in time. So all kind of input needs to be done in a holistic manner all across the spectrum.
I mean, that leads me on to my next question there. You're talking about other options and a more holistic approach to something. What are those other options for treating chronic pain other than opioids?
I think at the Walton Centre we've got a really, really good pain management programme. So that incorporates a psychologist, occupational therapist, physiotherapist, nurses, consultants in pain, and we educate the patients, and all the different disciplines will help that patient from a holistic perspective to manage their pain and to live well alongside the pain, hopefully without opioids. And that's one of the things that we would offer, as a non-pharmacological option to help.
And how do people stop taking them? I'm guessing that you can't just stop one day.
Yeah, no, I think that's really important. What we do is we advocate a stepwise reduction, and we check in with patients really regularly, so they would have a review every month or every 3 weeks. And we also have a support line, so patients can contact us in between appointments if they're really struggling. But it's around having agreement and us both having a conversation around an appropriate dose restriction and what they can sort of feel that they can deal with and balance that out, really.
Well, because I guess that must bring up a lot of anxiety about what's going to happen. How am I going to feel? Am I going to be in a lot of pain?
Absolutely. And we do appreciate that it's a really difficult step for patients to take.
Yeah.
And I think that's part and parcel of it, is for the relationship that as a nursing team, we are a small team, but that we can support our patients through this, because we appreciate it's a difficult process and their pain is still the same. Conversely, for some patients, you might find that their pain actually does improve on a lower dose of an opioid, which is very difficult for patients to understand, in all fairness, and we do appreciate that. But it is a reasonable sort of adjustments for them, and doing it in small bite-sized sort of steps, really.
Yeah. And the word addiction has been mentioned, and that's obviously an issue in this situation. I'll start with you, Yasir. What about people who can't stop? What are the steps that you'd take then?
That's a very good question there. So individuals who are using these medications for quite some time develop physical dependence, as we've heard earlier on. Physiologically and chemically, your body kind of needs those chemicals like opioids. And some people engage in certain types of behavior which are defined as addictive behavior, where they start taking medication over and above what they're prescribed, or they stop taking it for reasons other than for what they were prescribed. For example, opioid was prescribed for pain, but they feel, well, you know what, it's actually helping me relax a bit. So I might just take an extra tablet to have a better night's sleep, or it was a stressful day. So those elements need to be addressed and identified. And as very nicely mentioned by my colleagues here, you need to go through a pain management program, and you need to taper down your medication in a very slow and gradual manner. What we've seen sometimes is people have been identified to have had this problem, and on occasion you would have the prescriber suddenly stopping the medication, which can in itself cause lots of problems, concerns, and a lot of withdrawal symptoms which aren't pleasant. So it needs to be tapered down in a manner which is suitable to the patient's needs and their presentation. And clinically, if we feel it's more complicated and they need much more higher doses of medication, then you can provide them with what we call a opiate substitute treatment, which is then slowly and gradually reduced as well. The non-pharmacological interventions are very essential to manage pain, and they have to really, right at the beginning, when they start developing chronic pain, sit down, have a chat with your physician, and discuss your goals. Sometimes chronic pain is something that you'll always live with, and you have to adapt your lifestyle to make sure you're able to live well with it.
And are there statistics or research about how many people end up being addicted to this kind of medication?
I think the absolute addiction number is quite low in chronic pain patients. There's around 3% is quoted in the UK. Like I said, everybody will more or less get dependent on the opioids, so you have to deal with the tapering strategies we use, to slowly reduce the painkillers rather than abruptly stopping them. But I agree with Yasir that there's kind of a big limit, to offer patients this non-pharmacological help from the start, and then people get obviously in this dire situations where they're on high doses of opioids and they need to come to us. And I think what we have to do now is to take them down on opioids before we can actually send them to the pain management program, because they are too sleepy and too drowsy to follow what we want to teach them. And we don't want to re-medicalize them too much when they have learned non-pharmacological ways to cope with pain. But I think we have been very successful in the last 10 years, to get most patients up. So I think most patients actually succeed in coming off the opioids. And I think the encouraging part of this job is, that they feel much better of it. And I think their quality of life and their family's quality of life is improved, by the whole process.
Yeah. Now, Yasir mentioned people using these drugs for not necessarily what they were initially intended for. Kathy, do you think that's more of a problem in America? And if you do, why is that, do you think?
Yes, there's definitely more of an opioid crisis in America than there is in the UK. One of the reasons for this is because of the aggressive marketing of opioids early on in the American opioid crisis. And this has led to probably lax prescribing practices initially, which have been rolled out. So you've got a much larger amount of legacy prescriptions. So people who were prescribed opioids originally and have just been, initiated a prescription since then. In the UK, opioids are no longer recommended as a first treatment for chronic pain. So we've changed the health guidelines in that. And I think one of the things we've probably been trying to do in conjunction with the Walton Centre is to upskill the GPs and the pharmacists to allow them to have those conversations with patients earlier on and try that tapering and that education process within primary care so that we don't get these large number of patients that are being referred to specialist pain clinics. But, there's massive resource implications. Everyone who's working in the health services are under a lot of strain. There's very low capacity to be able to support patients with this within primary care as well. I don't know if Bernard, you had anything to add to that?
Yeah, I think we just tried to do a kind of a project where we try to take some of the pain management skills we teach people on the program and help pharmacists and GPs to deliver a kind of a trimmed down version of it, to help patients, giving them alternatives and opioids. And unfortunately, we could only recruit half of the patients we were intending to, because there's a lot of strain and work pressures in primary care to support this. So I think it led everybody to realize that what we do on the pain management program is quite time and resource intense. So I think there need to be some willingness, that gets supported as well in terms of healthcare planning in the future, and to help this huge number of patients early on and don't let them escalate in what we have to deal with then in the Walton Centre.
Yeah, and you see, Kathy mentioned the word crisis in relation to America. Is that the same situation here to a lesser extent, or?
It is the same because it was a huge epidemic over there. I sometimes suggest that there is a kind of a small epidemic, but it's a hidden epidemic that we don't know about because there's a lot of people who are dependent on these medications might not be aware themselves. And we're reviewing our prescribing practices in this country in a very robust and centralized manner. But one thing I'd like to highlight is almost 1/3 of the UK population is suggested to have chronic pain. I don't know how much of how many of them are prescribed opioids, but the NHS Business Authority suggests that we've reduced our overall opioid prescription in the past 5 years by almost 6 to 8%. But one area that has not been properly looked at and looked into is online purchase of opioids, which isn't a highly regulated area. People can buy opioids through online pharmacies, which aren't based in the UK. They're not sometimes even based in the European Union. And we recently did a study in 2021 during the time of the pandemic to see search trends for people who are buying medication. And 2 opioids were the toppest trend of people searching to buy online. So that area isn't regulated. We don't know how much of that is coming in and how much people are using, as much as it is not at the scale that we saw in the US because, as Kathy said, of the marketing and the way the healthcare is structured over there. We are different and our healthcare structure is very centralized and standardized. But yet we still feel that such services, the kind that Walton delivers, is absolutely brilliant. We don't have such services across the country. There is no standard approach to addressing this. There have been attempts. Public Health England has released some guidelines about prescribed drug dependence, but when it comes to commissioning, when it comes to delivering services, there's still a lot of gap, and it's quite fractured in the way these patients seek help. So if they have addiction, they find it difficult to go to addiction services because they feel it's for hardcore addiction and for those who are using heroin. And a lot of people in primary care setting where these clients or patients can go to are not either set up in that way to help them, or their service lacks those skill sets. So there's still a lot of gap in the service, and we're still not really sure of the level of dependence across the country.
So you're obviously doing amazing work at the Walton Centre, and this podcast is quite specific to Liverpool. It's been commissioned by Liverpool John Moores University. Would you say that it could be a completely different story based on where you are in the country?
I think we see a lot of patients from all over the country, patients that have been referred in from other areas who don't have a service like ours. We are fortunate enough to have a consultant, 2 specialist nurses and a psychologist, and easy links to the pain management programme and the physiotherapist, but not every area has those resources.
Yeah, so it's interesting that people are having to travel from different parts of the country to Liverpool to access help that they obviously need, Janet.
Yeah, I mean, as Ruth said, we have patients throughout the country, so the northeast, Newcastle, that type of area, in the Midlands as well. So we do have obviously within Wales, so we do have quite a diverse sort of group of patients.
And if there's somebody listening to this now who is either very aware that they have an issue with this, or it's maybe set off alarm bells. Yasir was saying lots of people might not be aware that they do have an addiction to this medication. What is the first kind of port of call? What should people do if they're sitting there and they feel like they do need this additional support?
I think one of the attempts, with collaboration with John Moores University is that, to make more healthcare workers aware, particularly pharmacists, who can see what they're handing out to patients, on a day-to-day basis. And there should be the first port of call, to see if they can get an appointment with their GPs and discuss, if it's in an amount of guidelines you should be on for chronic pain, or if it's too much. And if it's too much, then probably devise a kind of a tapering plan, slowly with the GP and pharmacist. And obviously, if everything struggles and they really have more addiction problems, that they need kind of support from a mental health specialist like Kasmia, or if the pain then becomes a big troublesome issue, then it might be better to then refer them to pain services, and then they can get a proper assessment, and then we can help, with other options.
Okay, and we can put some of those in the show notes. So if you are listening and you do feel like you need some additional support, like I said, just refer to the show notes. So I think this conversation's been really interesting. So thank you everyone for joining us.
Thank you.
You've been listening to Mindful Merseyside, brought to you by the Institute for Health Research at Liverpool John Moores University and produced by Inabella Media. We hope you found the conversation informative and insightful. If you or someone you know has been affected by any of the issues discussed in this episode, please refer to the help and resources listed in the show notes for details of organisations that can provide support. I've been your host, Gemma Cutting, and don't forget to subscribe to Mindful Merseyside wherever you get your podcasts. Thanks again for listening, and I hope you'll join us again soon.